that particularly in terms of stroke, that central pressure is a better predictor than pressure in the arm. But we're still measuring pressure in the arm. This is interesting data from Carmel McInnery and ourselves in Cambridge. And what we did is we defined what category of hypertension the patient had based on the guidelines. So we defined them by their brachial guideline pressures, and then we looked at central pressures. So if you look at people who are defined as high normal on their brachial and stage 1 on their brachial, there's a 70% overlap, which suggests that some people that you're treating may not need to be treated, and other people that you aren't treating may indeed need to be treated. So there's a very big overlap. So the European guidelines said that drugs would have a differential effect. Is that true? Well, let's see. This is data from Trevor Morgan in Australia, who used the sphygmocor system, and he rotated his patients through 4 of the common antihypertensive drugs: ACE inhibitors, beta blockers, calcium channel blockers, and diuretics. And as well as measuring their brachial pressure, he measured their central pressure using the sphygmocor system that I've showed you. So if you look at brachial pressure, there's no difference between the ACE inhibitor and the beta blocker. So if you only measured pressure in the arm, you'd say these drugs were the same, just like in the LIFE study. They're the same. They lower pressure to the same degree. But if you measure central pressure, you can see that the ACE inhibitor is far more effective, this is the fall in pressure here, than the beta blocker. Far more effective. Much greater reduction in central pressure than the beta blocker. So this is the famous Ascot trial, which again was a trial that was comparing the older antihypertensive agents with the more recent ones, and they compared an atenolol-based regime. You're probably going to gather that I don't like atenolol, and I'm going to show you some data. I mean, I wouldn't give atenolol. The only person I'd give atenolol to really would be my mother-in-law, I guess. But so no, I'm only joking. So they compared these 2 regimes, and you can see in terms of systolic and diastolic, no difference in reduction in systolic and diastolic pressure. So the drugs were exactly the same. But when you looked at outcome, there was a reduction in stroke in the amlodipine regime, and indeed there was a reduction in all-cause mortality. So again, on the face of it, this looked like there was a blood pressure independent effect. But remember, it's brachial blood pressure. So is there benefit beyond blood pressure reduction? Well, the good news is that unlike the LIFE study, we were able to prevail on the investigators, and in a sub-study of Ascot, we got them to measure central blood pressure as well using the sphygmocor system. And based on what I've said to you, and based on what I've shown you, you could guess what the results are going to be. And here they are. If you look at systolic blood pressure, no difference between the 2 drugs. But hey, when you look at central pressure, there's nearly a 5 millimeter of mercury difference in central pressure compared with amlodipine compared to atenolol. 5 millimeters of mercury. And that's very significant, suggesting that the effects of the overall study were not it reduces outcome irrespective of blood pressure. It means that it was central blood pressure reduction that was giving them the benefits, particularly in terms of stroke. But in the LIFE study, they didn't have a sub-study. There was no central pressure measurement. So we thought we'd do our own mini LIFE study in Cambridge. So we did exactly that. So we did a double-blind, randomized crossover study, and we looked at not losartan, but we looked at eprosartan, which is another angiotensin II receptor blocker. And you can see here atenolol in the blue, eprosartan in the purple. No difference in reduction in the pressure in the arm between the 2 drugs. But hey, when you look at the aorta, then iprosartan produces a significantly greater reduction in central pressure than atenolol. So suggesting that that's probably what was happening in the life study as well. And not only that, it was physiologically important as well. You can see that if you looked at N-terminal pro-BNP, atenolol actually put BNP up, whereas iprosartan lowered it. So the heart is actually seeing this difference in central pressure. So what about combination treatment? Well, I'm here in Bridgeport, so I've got to show you some American studies, and you'll all know about the ACCOMPLISH study. And the ACCOMPLISH study used benazepril with amlodipine or benazepril with a diuretic hydrochlorothiazide, and no difference between the two combinations in terms of systolic and diastolic pressure reduction. But you're all going to sing out. Benazepril and amlodipine produced a greater reduction in the composite endpoint, but there was no central pressure measurement in this trial. And you can guess what was happening between the two regimes. This is a study from Paris, from Stéphane Laurent's group, and they were looking at a combination of amlodipine with valsartan or amlodipine with atenolol. So this is the brachial pressure data. No differences between the two regimes, the amlodipine and valsartan here in red, and the amlodipine and atenolol here in blue. And if you look at systolic pressure, you can see here no differences in brachial pressure reduction, but the regime of amlodipine plus valsartan is more effective at lowering central aortic pressure than the amlodipine and atenolol. So this is kind of why I don't like atenolol, because atenolol is bad on its own. If you put it in combination, it's still bad. And if you look at pulse pressure reduction, the same. This is brachial pulse pressure. No difference between the regimes in the brachial, but again, the amlodipine valsartan combination more effective than the amlodipine atenolol combination in lowering central aortic pulse pressure. And again, there's no difference in pulse wave velocity reduction between them, but you can see that the augmentation index is again reduced by the amlodipine valsartan combination as opposed to the amlodipine atenolol combination. This is our own data in people with isolated systolic hypertension. This is perindopril, atenolol, lercanidipine and bendrofluozide. This is either placebo or treated, and you can see that all the drugs reduce peripheral systolic pressure, brachial systolic pressure, but the only drug that doesn't reduce central pulse pressure significantly, hey, it's atenolol. So I'm hoping very much that I didn't risk putting it in my objectives, but I hope if anyone is using atenolol at this moment, when they leave this lecture theatre, they'll stop using it. So this is interesting data from Gary Mitchell, and you'll remember that there was a drug, omapatrilat, which is a combined NEP-ACE inhibitor. You remember this? It was incredibly effective at lowering central systolic and pulse pressure. Very, very effective. These were some of the biggest reductions in central pressure that had ever been achieved. Unfortunately, omapatrilat was withdrawn, as probably some of you remember, because it, particularly in black people, gave them angioedema. So it never really came into clinical use. So this is the parameter study, and this is comparing not a combination of a NEP-ACE inhibitor, but a NEP angiotensin II receptor blocker combination, sacubitril valsartan against olmesartan, which is a pure angiotensin II receptor blocker. And this is central aortic systolic pressure versus peripheral pressure at 12 weeks. And you can see that central pressure is reduced more than peripheral pressure at week 12. Unfortunately, by week 52, that wasn't maintained. But the problem with this is that a lot of people in the various groups had add-on treatment as per the protocol. But it did suggest that you were getting a benefit in terms of central pressure. So really, this is the only slide that I really want you to take note of. Just like the guideline said, central systolic pressure is different from peripheral systolic pressure. You can put as many invasive catheters in as you like, and this will hold true. Whoops. It's a better predictor of outcome than peripheral blood pressure. So why are we measuring peripheral blood pressure? And it's differentially affected by antihypertensive drugs. So what about brachial blood pressure and risk? Well, after people have been measuring brachial pressure, and I'm delighted that one of my colleagues, or ex-colleagues, because unfortunately he's no longer with us, Tom Pickering at Columbia, pioneered 24-hour ambulatory blood pressure. And it was a sensible suggestion that rather than just doing a single measurement, if you measured it over the whole day, that would be more predictive because that's what you're exposed to. And so he pioneered peripheral ambulatory monitoring. So what about brachial blood pressure and clinic versus 24-hour? Well, this is just one study from Denmark from a colleague of mine, Tine Hansen, and it's looking at over 7,000 people, showing clearly that there was a superior predictive value of daytime ambulatory over conventional monitoring. So, of course, ambulatory monitoring created two new diseases. And this is white coat hypertension. This is David Cameron. This slide has never been more appropriate for white coat hypertension because David Cameron, as many of you who follow history know, he was the one who decided they'd have a referendum on leaving the common market. So strangely, he probably puts 90% of the people in the UK puts their blood pressure up. And obviously, we had masked hypertension, which is people whose blood pressure was okay in the clinic, but was raised if you monitored it outside the clinic. And we know that both of these conditions have been shown to increase risk. So all well and good. So of course, the next logical thing to do would be to compare peripheral ambulatory monitoring with central blood pressure. And that was done Ed Licata's group in Taiwan, and this is looking at cardiovascular mortality, and you can see that brachial 24-hour pressure is just better than central systolic pressure, just. So we've come from brachial pressure, brachial ABPM, central versus brachial pressure, central's better, central versus ABPM, ABPM slightly better, but what about central versus brachial ABPM? Well, of course, we couldn't do that because there was no way we could do central 24-hour pressure because most of the systems, as you saw, were tonometrically based. So myself included, a lot of us were very pleased when this system was introduced, the mobilograph, and the mobilograph essentially is using the brachial waveform rather than the radial waveform, and so you can use a brachial cuff just like the ABPM. And for the last 10 seconds of cuff deflation, it captures the brachial waveform, and then in the same way as the sphygmocore and other systems, submits that waveform to harmonic degradation and Fourier analysis with a transfer function which they call the arc solver. So basically, the company that introduced this had a big track record in ABPM in Germany, and they saw the way things were going, so they sent their engineers down to a coal mine in Chile, and they said, come up with an algorithm and then we'll bring you up from the coal mine. Actually, they collaborated with the Vienna Institute of Technology. So they developed this algorithm, and so this is their comparison of their cuff-based measure with the sphygmocore, and these are the Bland-Altman plots, which are pretty good. Well, as Francesco knows, myself and Ian are pretty demanding, and we wrote the editorial to their paper and said that, you know, I'm sorry, this is very interesting because it's bringing it a step closer to using it in the masses, but we want to see some invasive validation data. So they stuck our faces up on their dartboard and, you know, maligned us, but they knuckled down and went to Austria and did some invasive studies. And you can see that the invasive studies showed a good agreement. And this is one of the traces that you will get from the mobilograph system. And what's interesting about this trace is that the amplification, the difference between systolic and diastolic pressure, varies throughout the day. So here, there's very little difference between systolic in the arm and the aorta. Here, there's much more difference. So we didn't know that because we were just, until then, looking at a single measure of amplification at a single time point. What it means, we still don't know yet. So what about central ABPM and risk? You would predict that the best risk predictor of all would be 24-hour central pressure, because that's what your heart is seeing 24 hours a day. That's what your brain is seeing 24 hours a day. So the French group did that, and they rather, in a tribute to Michel Safar, called it the Safar study. I can't remember what it stands for, but it was the Safar study. And so they looked in terms of left ventricular hypertrophy, whether 24-hour aortic was better than 24-hour brachial in terms of prediction of left ventricular hypertrophy. And one of the things that you have to do with the waveform is calibrate the waveform. And there was two ways of calibrating the waveform. You can calibrate it against systolic and diastolic, or you can calibrate it against mean and diastolic. And they used both calibration methods so they could compare them. And when you look here, this is the ROC curve, and this is the area under the curve. And clearly, 24-hour aortic pressure measured with the second calibration method, mean and diastolic, was much better than office or 24-hour brachial pressure in terms of left ventricular hypertrophy. They'd read our paper, so they did exactly what we did. They defined a definition of type of hypertension based on brachial 24-hour, and just like we did in terms of the point measurements, there was an overlap in terms of brachial and central measurements. Again, suggesting that there may be people that you're treating who don't need treatment and people that you're not treating who do. So this is our data from Cambridge again, and this is looking at brachial and central pressure. And you can see here that particularly at night, there's much less difference between brachial and central pressure, but it varies throughout, it varies throughout the day. This is amplification itself, which tends to go down at night. So what about central pressure 24 hours in carotid IMT? Well, we looked at this in our Anglo-Cardiff collaboration trial. We came up with this, not surprisingly, deliberately, because we're now up to Act 4, and if anyone can come up with an acronym swan song, Ian is suggesting, because of my advanced age, we need to do a swan song study, but we haven't got there yet. But we are like Shakespeare, up to Act 4. But this is ACT data. This is Anglo-Cardiff Collaborative Trust. This is a huge study looking at normal vascular aging, and it's the biggest study currently in the world. So we use data from the ACT study, and these people were treatment naive, nearly 500. You can see that their mean age was 50, probably slightly more females, and their blood pressure was okay. But if you looked at univariate correlations here, then aortic systolic and aortic pulse pressure were better than brachial and systolic and pulse pressure. And this is a multiple regression model, and you can see that aortic systolic pressure remains predictive when you submit the data. So I'm finally going to finish on left ventricular assist devices, which is one of the things that I'm doing at Columbia, and brought me into contact with Francesco, who turned out to be an incredibly good clinical investigator. So we're looking forward to having you back in New York, Francesco, although I'm sure you'll be sadly missed here. So basically, as you know, if you've got severe heart failure and you're on optimal medical therapy, you probably don't do so well. But if you have a heart transplant, you do very well. But the problem is that there's a donor shortage, although I went to the meeting at Columbia last week and I gather there's been a slight uptake in donors because of the opioid crisis. So the one good thing the Sacklers have done is provide more donors for transplants. And of course, these people tend to be Hep C infected, but the good news is, of course, you can transplant people who are Hep C because you can cure them after you've transplanted them. So because of this, a number of devices have been developed to maintain circulation while the patient is waiting for a transplant, bridge to transplant, or euphemistically it's called destination therapy, although that definition is going to go because some people are going to have assist devices in for the rest of their lives because of the donor shortage. But the problem with these devices is that they're not pulsatile, so flow is continuous. So not surprisingly, it's quite difficult to measure blood pressure in these people because they really haven't got much of a pulse pressure. And so blood pressure measurement is difficult. There's Doppler techniques to do it. But blood pressure is important because this is looking at the incidence of stroke. And one of the unfortunate side effects of having one of these devices in is stroke. So if you look at time to stroke here, if you are above the median pressure, you're more likely to have a stroke, and the cutoff in the ROC curve is about 102 systolic, which I think is similar to our data at Columbia, isn't it, Francesco? We have a similar cut. So again, you make mistakes. 5 years ago, the people from IEM who had the mobilograph came to Columbia, and we sat in the conference room and we were discussing this device. All we had to do was actually go down 2 floors and put it on someone with an IVAD, and our research would have been 5 years advanced from where it is now, because when you do put this device on someone with an IVAD, for whatever reason, it does measure their pressure. And this is the comparison of the mobilograph pressure with an A-line. And these are the Bland-Altman plots. And you can see here the standard deviation is 6.4, which I'm told the FDA would accept. So it's valid. These are the correlations here, systolic, diastolic, MAP, and pulse pressure. And this is just graphically showing the difference between the A-line and the mobilograph. And this is now published. It was published last year. So this was very exciting because it now raises the possibility for the very first time that we can look at 24-hour pressure in people with an LVAD. Not only 24-hour pressure in their arm, but 24-hour central pressure. So we put this system on them, we give them the system to take home, and we give them a FedEx box to send it back. And so far, we haven't seen any on eBay. They've tended to come back. So I think this is very, very exciting data. So I finished with this slide. I make no excuses because here I am, and I think you're in this picture as well, Francesco. This is the bridge between PH and the Milstein, and indeed, amazing things are happening there, and it has been my absolute privilege to be part of some of the amazing things that have been happening there. And I'm sure that you're now associated with Yale, so I'm sure that amazing things are going to be happening here soon. So I will stop there. I'm just about on time, and I'd be pleased to take any questions. If you have to rush off, don't worry. You're very welcome to take the slides from the desktop. And finally, thank you, Francesco, for making this possible, and thank you for inviting me here. I've enjoyed every minute of it, and I hope you'll go away thinking a few different thoughts. Thank you very much.
Thank you for a wonderful lecture. I have a question, but I'm going to let the audience hold first. Any questions we can entertain for you folks?
So I don't understand why the central pressure is not reflected in the I mean, with certain drugs you see some differences in central pressure. You don't see that when you do the I don't understand why that's
Well, no, because if you look at diastolic pressure and mean pressure, there's no difference between the two, but systolic pressure gets amplified as you go from the aorta to the brachial artery. So that's why there's a difference. If that amplification was the same for every individual, if it was fixed, then there would be a direct relationship, but it isn't fixed. Some people have longer arms, some people are short. I mean, if you look at augmentation index, wave reflection, strangely, women have higher augmentation indexes, and not surprisingly, because they're shorter. So the end of the bath is nearer, when you're doing the hemodynamics. So the bottom line is that everybody is different. And again, as you get older, that relationship changes as well. So
No, I understand that, but in the same patient after treatment with, for example, AIDS, you notice AIDS. You notice.
Oh yeah, no, the treatment thing. That's a very good question, because our treatment of blood pressure is completely in the dark ages, because we go on guidelines and we go on systolic and diastolic pressure. You could have 10 people here and their blood glucose is 200, so they're diabetic. Who's type 1 and who's type 2? You don't know. You have 10 people who've got systolic blood pressure of 60. They're not the same. If you've got a systolic blood pressure of 60 and a brachial pressure of 100, you've got essential hypertension, which is usually in young people. If you've got a systolic pressure of 160, but a diastolic of 60, you've got isolated systolic hypertension. These are two completely different conditions. So basically, what you should be doing, I don't care about whether what the BMI of the patient is or the weight of the patient. I don't care. I know Donald Trump told them to make his height bigger, but I don't care, because I can see Donald Trump's fat. I don't need his BMI. So what I want, and the one thing we're short of at the moment, is cardiac output. I want one machine, which is cuff-based. The nurse puts it on, and she gives me, on my desk, the patient's cardiac output, the patient's wave reflection, the patient's central blood pressure, and the patient's pulse wave velocity. And I will give them, based on data that I haven't showed you, but it's been done, the appropriate drug for their hemodynamic abnormality. So you've got two people, both with a systolic pressure of 160, with totally different hemodynamic profiles, and you should give them the drug that is appropriate for their hemodynamic profile. That's the other question is, if you look, I'm not against all beta blockers, and those of you who read Jack will see I've written a letter to Jack after one of Mesley's things saying, atenolol is dead, long live beta blockade. So I'm not against